game-changing discussions on the big ideas that shape our thinking. This is One2One.
Dr Abuchi Okaro is a consultant general upper gastrointestinal and metabolic surgeon, and previously a consultant surgeon at Maidstone and Tunbridge Wells UK NHS Trust. He's a pioneer of weight loss and bariatric surgery in West Africa, and co-founder of one of Nigeria's first dedicated diagnostic and therapeutic endoscopy centers. His work has changed thousands of lives, reshaped what is possible in minimally invasive surgery, and helped build the foundations of a new era of metabolic and gastrointestinal care in the region. Abuchi Okaro, welcome to One2One.
Thank you. Thank you.
Thank you for joining us.
Thank you for inviting me.
Abuchi Okaro, you are a highly accomplished general laparoscopic bariatric and upper gastrointestinal surgeon with over 2 decades of advanced surgical experience across the United Kingdom, Japan, no less, and Nigeria. I would broaden that to say West Africa, actually. Okay, given the fact that I know that you do some work in Ghana, don't you, from time to time. You're widely recognized for your expertise in minimally invasive weight loss surgery, and I would like to talk a bit more about that later on. Advanced gastrointestinal surgery and complex upper GI cancer operations. You've served as a senior consultant, or you still do serve as a senior consultant at Eurocare, multi-specialist hospital. You hold consultant positions at the very highly regarded Wellington Hospital in London and Benenden Hospital in Kent. You trained, thinking and talking about your early career, you trained originally as a doctor. You graduated from the University of Nigeria, Enugu campus. That's where your beginnings. Incidentally, your illustrious father, whom I remember so very well, an eminent obstetrician and gynecologist, must have been a huge influence on your life and trajectory.
He definitely was.
Absolutely. I mean, I certainly remember him very, very fondly. You have a brother, of course, a guy who followed in his footsteps in obstetrics. You never considered that path, did you? Not really. No, you were born to be a surgeon. So you began your career in earnest in the UK National Health Service, is that correct? You completed basic postgraduate surgical training in the North East Thames Deanery initially, and you became a fellow of the Royal College of Surgeons of England in 97. In 98, you commenced a Master Surgery program at the University of London. You conducted research, surgical training, further surgical training at the Royal Free, Royal London Hospitals, and you were awarded that coveted MS degree eventually in 2004. You completed higher surgical training, general surgery in 2006, with subspecialist interests in upper GI surgery. In the same year, you went off to Japan, and that must have been quite a transformative experience. International fellowship in upper GI surgical oncology at the National Cancer Center in Tokyo, one of the world's leading institutions for esophageal and gastric surgery. That must have been amazing. I'm sure that the prevalence of that particular disease in that area is quite different from what you must have seen in the UK and here. And then eventually you were appointed, of course, consultant upper GI and bariatric surgeon at Maidstone, Tunbridge Wells in 2006, following an extensive period of academic and specialist training in several London hospitals we've already talked about. Quite a journey, quite a journey. So here's my question to you to begin with. You began your training in Nigeria, then across to the UK. Tell me what those early experiences did in shaping your conviction that surgery was indeed your calling.
So thank you for, I have to remember some of the, yes, that I have actually been through some of those tough journeys. It is a while, I must say, but I always wanted to be a surgeon. I think possibly from when I was about 12. My father was a doctor, my mother a doctor. So we grew up in the corridors of hospitals. So I always wanted to be a doctor. Not that my dad said so, but I always knew I wanted to be a doctor. Same with my older brother, Emeka, as you mentioned. But I specifically wanted to be a surgeon. Don't know why. So I had that very young. Now, luckily or unluckily, the sort of the structure at home with my both parents being doctors, and of course my brother, I think made it easy in terms of, maybe conversations about where to go to medical school, what to do to get into medical school. And then, of course, I suppose the normal kind of conversation around that you just have to get on with it. You just have to get on with it. And I think I will say that my parents are really liberal. I think back now, and I look at how my father and my mother were very, very liberal, very, 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 they just let you do what you feel you wanted to do. But because I came from a network with only boys and I had a twin brother, so I think within that system, we were very keen to look out for each other, of course, and encourage. And then, fast forward, graduated from medical school, went on to do my house job at Luth, and then went straight to the UK to start my postgraduate training.
Yeah, and that's a very well-worn path, isn't it? Nigerians, Africans who go off, lots of blood, sweat, toil and tears up there, training, that's brought you to this point. So Abuchi, you were appointed consultant, surgeon at Maidstone, Tunbridge Wells NHS Trust in 2006. You've since retired from the NHS. I know that. You held that post up until 2019 or thereabouts.
That's right.
I'd like to know, what did stepping into that role? I mean, bearing in mind before you answer this question that you are, of course, went over there as a kid from Nigeria. All of this sweat and toil and grit you've discussed and everything you've gone through. And finally, you're there, supposedly at the pinnacle of your career, as you could envisage it at that point. What did stepping into that mean to you, given where you were coming from?
There's really one emotion that stands out for me in response to that question, and I discussed this. I said this to the wife. I said this to a few friends. I got appointed as a consultant surgeon. I got appointed in 2005, and then obviously went to Japan, and then came back and assumed my position in 2006. And I started within a week or two. Of course, I was very, very, very pleased, very happy, very chuffed, as they say. But I felt empty. I thought, and that came across very quickly. Looking back now and understanding a little bit of what they call the hedonistic, you get the height of the dopamine, and then you get a drop, top to the mountain, looking down. What's the next mountain? So I began, because that's what happened, and I realized that I didn't
anticlimax.
Correct. Didn't know then. I just felt, So yes, and I started looking elsewhere, and of course Nigeria came right on my radar. But I need to start coming back to Nigeria, one way or the other.
So we'll come back and talk about your experience in Nigeria. You started out quite early in your career, turning your attention back. And I remember those years very, very well. So I'd like to come back and talk about that properly. But sticking with your time in the NHS and the running up to becoming a consultant, working as a consultant, bearing in mind the fact that there came a point at which you were doing that with Nigeria side by side. But we're still talking about high volumes, high stakes work you're doing as a surgeon across continents. What were the most important lessons you learned during those consultant years?
In the NHS?
Yeah. But primarily in the NHS at the time.
I think some, if I understand your question correctly, I think some of the big lessons were, pull to your strengths, really. which means that, as a general surgeon, obviously upper GI specialty, I was well trained. I have to mention that. I think my training in the southwest of Southeast Thames, I worked with some amazing, talented surgeons, really gifted surgeons for over about 7 years as a registrar, then a senior registrar. And they really, some of them were amazing surgeons, and I got on well. So I went into consultant role very well trained, technically.
Yes, of course.
So that, I think, was a massive help, because actually once I started my consultant job doing complex upper GI surgery, esophagectomies, gastrectomies, I've been to Japan. It's really good. Technically good. So I didn't really have a big issue of maybe, struggling in theater. No. I was very lucky. So, of course, it reminded me that, it's about your surgery is about technical, plus, of course, decision making. Now, you realize that gets you so far. And then other things importantly come along. I talked about decision making, very important. Who are you working with? Who are the people you are spending time with? Colleagues, the environment. Started to play a role, and then, of course, the classic human nature issues of competition and jealousy. And so they just come in, and then you begin to realize that sometimes, you got to dim your light sometimes.
Yes. So you've just invited me to press in a little bit further into that. This is a lone surgeon from an African Nigerian background who's out there, who's bloody good, who's doing some excellent work. Yet you're talking to me about having to dim your light. What's that all about?
You work in England, you work in Britain, you understand that there are undiscussed, undiscussable, right? We deal with, and that's just human nature. You figure that out. So sort of to summarize or to sort of, what was clear to me is that in my mind, that my real ability to do and function the way and do what I wanted to do and how I wanted to reach my maximum potentially wasn't going to be in Britain. Right. I mean, again, it didn't come as a big, massive flash, but I knew I needed to come home.
So it sounds to me, Abuchi, as though, feels to me anyway, that much of everything we've discussed so far is leading up to this point, to talk about your work in Nigeria, which I know you're very keen to talk about. I am as well. So you pioneered metabolic bariatric surgery, metabolic weight loss surgery, bariatric surgery services in Nigeria, didn't you? You've been coming back since the 2000s to do this side by side with your consultant job and everything else you were doing in the NHS. I'd like to know, we're moving on to talk about obesity here. What do you think most people still misunderstand about obesity as a disease? And first of all, is there even an obesity epidemic in Africa?
I think you were really precise in that description. It is a disease. And I think that's a misunderstanding that I think a lot of the international sort of community have been working hard to define it in terms of nomenclature, in terms of diagnosis, and then, of course, subsequent kind of treatment. So yes, that really was a bit of an obstacle in the definition of obesity as a disease rather than as a condition. So that's the first thing. And I think Nigeria is, incorporated into that. But I think, the reaction or the response to actually, obviously, why is there an epidemic or is there an epidemic? I think clearly there is. It's global. Of course, Nigeria has a bulk share. But the other way of looking at it is looking at some of the consequences of obesity, let's say hypertension, for example, or had type 2 diabetes, then, polycystic ovarian syndromes and the infertility, and then, and so on. So if you're looking at it through either lens of the outcomes of being obese or the actual condition itself, it's just getting worse. And also, as I'm sure you would probably want us to touch on, is the childhood obesity. I mean, in Nigeria and globally, it's very concerning.
Absolutely. So you just described for us, and you laid a fantastic foundation for many of the other things that we'll talk about in this conversation. You've just described for us a constellation of conditions and diseases that revolve around obesity. You've talked about type 2 diabetes, polycystic ovarian syndrome, talked about hypertension. So we're moving on to your work now. These are metabolic conditions or diseases. So leading on to your work as a bariatric surgeon, doing weight loss, obesity surgery, can you help me understand what that is and why that has a place in amongst all of this?
What we do is we do some procedures on the upper gastrointestinal tract, which is to either make the stomach smaller or make it smaller and then do the bypass, which essentially means that we either restrict, which means calorie restriction, so the quantity and the volume of the food that one can consume on any particular sitting goes down.
By reducing the size of the stomach.
By reducing the size of the stomach. A classic case would be like the lap sleeve gastrectomy, for example. And then that has some added benefits. So not only are you now not able to eat, you eat less, but you're also having some changes in the physiology and biochemistry of the body. So ghrelin and so on, which is to the brain and the nervous system, which makes you less hungry. It also makes you get full quicker, which ultimately then means you eat less. It also speeds up your digestion, which means that you have but the ultimate point is that you eat and consume less and your body handles calories in a slightly different way. And the impact of that is weight loss over time. So that's what the classic restriction does. Now, when you add in something like a bypass or a switch also, what you're doing is you are now excluding a portion of the very long digestive small intestine tract from absorption. So let's say a gastric bypass, for example. And the bottom line is that there's certain foods that will come through and not be absorbed. And ultimately you end up with again. So it's all about getting less calories, less want for food, which is an addictive behavior change. And of course, a change in the body functional processing of sugar through insulin and so on. That ultimately allow people to lose weight.
Yeah.
So that's the way we fight obesity with, let's say, surgery. So they're the two big ones, bypass and sleeve are the two big operations. And there are other operations which we don't really need to kind of touch on. But the point is we want to empower or enable a patient or an individual end up eating less over time, consequently lose weight, and hopefully maybe get their health better.
So just by way of laying a bit more foundation for what we'll go on to talk about next, we're talking with acknowledge the fact that there's certainly is a global epidemic obesity. Nigeria has its, and Africa has its fair share. There's a direct link with type 2 diabetes, a number of other conditions that we would call metabolic. And there is a benefit to what you do, bariatric surgery, weight loss surgery, in amongst other options, complementary therapies. But I'd like to ask, particularly in this environment, Nigeria, Africa, where is that obesity coming from? You talked about childhood obesity, for example. What is the genesis of that obesity in this environment?
It's definitely multifactorial. it's coming from different kind of areas. I think if we focus on the adult obesity, I think, and then maybe talk a little bit about the childhood obesity. Eat a lot more processed foods, which it's part of the westernization of our diets. Even the Nigerian diet, sadly, particularly the kind of they're very carb heavy. So there's a lot of bread, there's a lot of rice, there's a lot of fruit. These are all really rich carbohydrates. And they are staple diets for home. So not a surprise, the yams and so on. So we're very carb heavy in this part of the world. We also traditionally we run kind of fairly sedentary lifestyles. We're not as active as we could, partly because, of course, some sort of restriction. We're trying to get to work and earn a living. And then also, we have an extremely vibrant sort of beverage industry.
Yes.
You can get Coca-Cola or beer or lager. So I think
Just like that.
Yeah, I think it is just, you have to actually step back in order not to indulge, in order to prevent, I think, getting into the trap. So I think that's a big for the adults. For the children, I think it's the same as the adults, but I think in children's case, I think you got to add in the snacks and the sweets. There's a lot of sweets going on, snacks, and I think that just carries on all the way through to school. So yeah.
Yeah.
Unfortunately.
It's a deeply personal subject, isn't it? Not just clinical or even presentational. It's very deeply personal, isn't it? Question of weight and obesity and layered in and amongst it, all of that, of course, is a plethora of disease conditions revolve around it as well. So it really is a very, very important subject, and no wonder it's topical, particularly now.
Because it's treatable. It's reversible to an extent. Some of these are reversible conditions. I think we haven't really delved into the science, but the science suggests and very clearly demonstrates that, if you begin to correct some of these conditions, there's certainly a significant improvement in quality of life. There's a significant reduction in cardiovascular mortality. There's a significant reduction in cancer incidence and mortality. There's a significant incidence on need for joints and hip. You talk about self-esteem, you talk about mood, you talk about just life experience. So if you're looking at the science of it, I think there is just no doubt.
Absolutely. So we're really speaking about a very important subject here. And moving on to the topicality of it all, we've spent a lot of time talking about the constellation, of course, of diseases and conditions that revolve around obesity, the impact both psychologically and clinically, and some very deep personal experiences you shared from your patients here as well. But of course, these days there are what some would call alternatives to surgery, and I say that deliberately because I know that you will want to recalibrate the thinking here. But the rise of GLP-1 agonist medication, talking about Mounjaro, Ozempic, it sparked a global debate. And these really are, it's diabetes medication, isn't it? So how do these compare to surgery in terms of metabolic durability? Or how should we view these new treatments?
I think on really key, you're 100% correct. The rise of these small molecule compounds has really transformed the market, and I think to put it we got to put it in a sort of a global perspective. Obesity, in terms of incidence, is so large, so massive that you clearly need to have a ladder or kind of a scale for intervention. Because if you're looking at just unbelievable volumes, so I think that's the lens upon which I would probably kind of answer that question through, really. So these small molecules are really, they're amazing. They have really changed the landscape for all comers, because that's how it sort of became. It's like all comers, try this. So over the years, of course, some of the big communities that we know in bariatrics, if so, and some others have been watching and of course researching, because there's a huge amount of research going on behind the scenes. And I think what they're coming through to now agrees that there is an algorithm, are you with me, whereby if you look at the advantages of, let's say, Ozempics or the Mounjaros and compounds like them and the ones to come, because they are more to come, clearly. And then you look at the ability for what they can achieve, certainly in the short term, you really begin to see some difficulties now. I think Mounjaro data is about 15% total body weight in total, 15, maybe 18% at best. Ozempic is about loss in the best cohort of studies. I think Ozempic's about 10%, maybe 12. And you got to keep using them again and again and again, So when you look at that data, you really then see that people who have a certain amount of weight that needs to be lost based on, let's say, body mass index, for example. I'll give you a practical example. Somebody with a BMI of 50. Morbid obesity, super obesity. Trying a GLP-1 as a primary treatment is just a waste of time. You're never going to get them to the weight that's going to, I'll put them in a better category. Are you with me? Now, somebody with a BMI of 30 or 34, okay, yeah, worth it. So that's really what I think is coming through in conversation. But the other thing that's coming through that's really interesting is they're working synergistically. So we're using them together, particularly either to prep people towards surgery to help them lose some weight, because of course they may well be a bit of a morbidity issue. You may be looking at a situation where, for example, they have had the interventions and their weight might be coming back a little bit. You can then add it in. So it's becoming a bit like chemo and surgery therapy. In a way of speaking, you're combining therapies. So that's where we're at the moment. Yeah. But I must add the very important thing. I think it's more for patients in terms of their understanding, or at least their awareness, is that the problem with some of these compounds is that patients are taking them, and we're not talking about the side effects now because they're very few, but they are serious. But they take them, what they end up doing, sadly, is in as much as they benefit from them, they lose a combination of both muscle and fat. Because that's what these compounds do. You lose muscle bulk, you lose fat. And then what happens is if they stop the drugs, which you usually do, what they gain back is fat.
Absolutely.
So what happens is they've followed some of the long-term group of patients, and what they end up doing is that even though they rebound weight, they're rebounding at strictly fat. So the sarcopenia risk gets significantly higher. Which is why they encourage you to, be part of a program, to do it with a nutritionist plus a physician who's going to advise you on exercise, making sure you're training up your muscles, your protein intake, and so on. But we won't deep into that.
Of course, yeah.
But so that's where I think concerns are coming.
Yeah. So there does need to be a deep multidisciplinary approach to this. It does need to be guided. And from what I'm hearing you say, we are entering into an era of combined metabolic therapy, really. So I'd like you to tell me, and quite categorically too, is it helpful or harmful to frame medication and surgery as competing solutions? Because these medications are becoming available almost like sweets these days.
Correct, and they are. They literally are. Even in the US, you ring a toll-free number.
You get it.
Britain, Boots can give it to you, but you may have to do a Zoom meeting. So yeah, they are. But I think that's because of the, not just advantages, which I think are there, and we can't deny them. There's been a huge advantage. But also don't forget, it's pharma. It's big pharma.
Of course, it is.
It's big pharma, which kind of means, sadly, there's money to be made.
So society is framing, is polarizing these solutions almost organically and instinctively in the minds of people. So I'll put that question to you again, and I'm looking for a categorical statement. Is it helpful or harmful to consider them, to think of them as competing solutions?
It is harmful to see them, I think you're absolutely right, because they are complementary, I think. Now, where do I predict this is going based on a lot of the conversations that are going on in some of the bigger circles really, is that they will become a refined algorithm for these. Particularly in account of they'll be like, hey, don't take this now, have your procedure first, then come and take it later, or take it first and then come and have your procedure if it fails later. So, but that only really gets better done in the context of a clinical environment rather than ordering it off Amazon or, and I don't think that's going to really happen, but I think there will be some assembly of that in some centers.
Yeah.
Because they are complementary, without a doubt.
Indeed. So, Abuchi, talk me through. You are a surgeon, a practitioner of international repute. And we're talking about a complex subject here, complex therapies as well. So talk me through, help me understand the evidence-based algorithm or the procedure for prescribing these medications, or where surgery has a place. You talked about BMI and things like that earlier. Educate me properly from start to finish.
So in my practice, so what we do at our center is that a patient obviously this is when they come to us. So this is not people ordering on Amazon. So it cuts us of this, and they come and say they want to lose some weight, and we have a consultation with them. We firstly establish what their current weight is and their BMI, and I think any comorbidities. And then we really, I think the key question always for me is really, what's your target?
Yeah.
What journey do you want to get in terms of your weight?
What's your target?
Yes. So that's always my starting. So if a patient comes in X weight, what's your target? Now, if they tell me their target, the gap between their target and their present weight isn't going to be delivered by, let's say, Ozempic or Mounjaro, I make that very clear based on the data. Are you with me? Now, most of the conversations would go, so alternatives. And then we go through them. So I have to give them, the full, we always give them the full kind of optionality. Now, for patients who are super obese, so I know that their risk, either because of chronic obstructive sleep apnea or massive bad hypertension or diabetes, will be that their perioperative risk category puts them at severe, which means that their risk of getting complications is strictly higher.
If they go and
straight direct to surgery, I would not operate on them because, of course, that would impact on outcome.
Of course.
So then I would use, let's say, Ozempic or Mounjaro to reduce their weights pre-surgery, and then advise them, and then that's a very easy, comfortable way of using it. Now, we also have patients who, despite all conversations, insist on having, the GLP type, and then we would prescribe them for them for a limited period to see if it has an impact.
What does that mean? What's a limited period?
Depends. I mean, normally it's 2-3 months because you can obviously move the doses. Now, I haven't added here, which is very important to state, that I think they are, in my experience, they are usually 3 categories of patients. In my experience. The first category of patient is as a patient who is as well researched, done their homework, very informed, but has an open mind. And they come, we have a conversation because we, with a nutritionist, myself, and always together at the same interview, and we inform, and they kind of, take on board our the sort of data and go home and come and then comply, usually. And there's a second category of patient who has done their research, but are very emphatic, very, very clear. There are some no-go areas. I am not going to have an operation, doctor. You can't convince me.
You get them all over the world.
Correct. So once they make that clear, and I always establish that early in the conversation because it saves time, you then really know your options on the table are those GLP-1s, maybe a balloon or nothing. And then there's a third category of patient who isn't informed, but also doesn't know what they want and has no restriction. So they require a lot more work, because you have multiple conversations. So they're the 3 that I tend to kind of try and seek out very early in the conversation, so that we can
So we earlier on we talked about where this epidemic is coming from. We spoke about diet. We spoke about childhood obesity. I'd like to delve slightly deeper into that. And we're talking really about patients or individuals long before they come to you. What really should people be eating or not be eating in order to prevent the prospect of meeting Mr. Abuchi Okaro at some point further?
So this is the childhood obesity, right?
Start with childhood, you can go backwards.
I mean, a nutritionist, obviously, Cherise, who's my nutritionist, I'm hoping will agree with my comment now. But essentially, I think we have to look at the big offenders, processed foods, richer fast foods to a large extent. To a large extent.
And we're becoming an increasingly affluent society. These things are readily available.
We're in a rush. There's no time. Of course, there's they tend to be a little bit cheaper because, of course, they are, the ingredients aren't the most wholesome, and they're usually carb-based. They're majority carb-based, or they're fried, deep fried or stewed. So once you know that, then you want to move them to a slightly more wholesome foods. So they're going to be foods that are either grilled or boiled, less fried, roasted. You start in that category, and you kind of move them away from the carbs towards, something a little bit more protein-based, potentially, obviously fiber-based, salads. Lots of fruits, not the liquidized fruits, no fruit juice. You want them to have the raw fruit with the fiber, and so on. And then you want to get them out exercising and sticking to water, hydration, for example. And I think, so yes, my approach should be to be looking at trying to make your food a little bit more towards a protein, good fats, fiber diet, than the carbs. And then getting out and moving around. Particularly for the children, but also for the adults, But the bottom line is we're all addicted. We all have an addiction. Let's cut to the chase. We all have addictions to some degree. So we always try and get them to make their addictions positive. Make them constructive to their well-being if they have longevity in their view. These are the adults. The children, of course, is parental, of course. Sadly, children who tend to be more overweight tend to come from slightly more overweight families traditionally because of what's in the kitchen, what's in the pantry. It's habit, right? Habit is repetitive, subconscious, automatic, knee-jerk, no thinking. So it all goes to behavior, sadly. But then that means behavior can be changed, which is perfect, which is why the psychology gets important. The counseling, the coaching, the conversations, and the emotionality of it, which is why a consultation that I would have with Cherise and my patient can take an hour. I deeply want to know really if, what's going on, where are the traumas, and if you have a good patient report, this is the bit that comes out in studies, which is really quite powerful, which is why you have to always be, self-aware as a clinician yourself, is that the patients do things for their doctors deeply. If they have a true connection to their doctors and their clinicians, there's data suggesting they do more for the doctors and the nurses that they care and feel they like. That's been proven.
Absolutely.
So, that's why this is all kind of left and right brain thinking.
Yes.
Left and right brain.
Okay.
The emotionality with the logic. And if you link them, and there's positive reinforcement and there's support, you get the results.
Absolutely. So really, there is nothing superficial about any of this. This is a deeply involving subject that requires a constructive response born out of deep and collective thinking. And you do have to get the patient on side as well. That is absolutely true. You talked, or you alluded to, very quickly, to that funding gap, massive across Africa. Nigeria's share in that funding gap is very, very significant indeed. Talk to me about the existential problem that we had in healthcare in this country, which is funding. You being at the provider, the operator, how has that impacted the quality of service and the seamlessness of service you've been able to deliver?
So, if I understand your question correctly, of course, it's the availability of the funds and the cost of delivering service, and the gap. And of course, you at the helm of a very big international hospital in Lagos, so you are very aware of the difficulties that are there.
I was hoping to keep that off the table, Karen.
But it is a lens in which you're asking the question. I don't have an answer, to be very honest with you, Tux. I don't have an answer. What I can say is that my feeling was, if you've obviously got a massive journey and you have to just take one little step at a time. You just have to. It's too big a challenge otherwise. So what does that mean? What that means is that in your own ecosystem, where you have at least some ownership, some influence and control, is you try and keep yourself as lean as you can. You try and make sure you resist the urge to compromise on the quality of your work on account of margins. Really difficult. So what am I hoping? I'm hoping that we're going to actually get some of these funding gaps to be bridged with some of the big, some of the maybe insurance-based lifting, not just in terms of the volume, but also I think remuneration and so on. Because I think without that, then there's going to be a gap. You're just going to have little small silos. But if it's your conducting TV, but I really want to make one very important point, if I may. You asked really regarding Iwosan. You mentioned, of course, Richard Ajayi and others. Important key investors in the healthcare space. As I had watched over the 20 years or so, how venture capitalists and others were coming into the Nigerian space to make if I'm allowed to say, a quick buck, it disheartened me. Because, of course, healthcare isn't in these patient capitals.
Absolutely.
And we saw, certain organizations change hands 2, 3, 4 times. Now, and this is where I think I am, and of course you mentioned you had Tosin, right, on. It's what it should be. I was in Mumbai last year. The majority of all healthcare funding in Mumbai, in India, is by Indian multi-billionaires. And now when I started to see the trend happen here, I was overjoyed. Nigerians need to invest in healthcare in their country. So when I started to see the trend of Nigerians investing in healthcare in Nigeria, of course, you came from the organization where there was a single individual, which must be given credit for doing it through multiple distribution channels and hospitals. It's what we need. We need Nigerians to come in and generate and invest money and make it a patient capital kind of situation. But it's got to return. I appreciate that. So for me, I've been excited. It was on one. Of course, we had Tosin doing his. I think is really exciting. And I really think is what we need.
Absolutely.
Really, we need our local money, our country, our healthcare.
Absolutely. I mean, venture capital money, of course, is a quick buck, isn't it? And you've made the point. Healthcare needs patient capital. So yeah, it's very, very healthy trend indeed. So let's come back, Abuchi, to you as an individual, as a surgeon. You have extensive experience, of course, let's not forget, in both open and laparoscopic surgical work, including hernia repairs and all of that. I'd like to ask you about minimally invasive surgery. How do you feel that, to what extent do you feel like this has transformed the healthcare delivery space at the time that you've been involved in African healthcare?
I mean, I think simple answers is this huge. It's amazing. The transformation is, I think, has been phenomenal. We didn't talk specifically about the training setups and so on, but as you know, some of the stuff we used to do with Professor Chris Bode in Luth, set up the Laparoscopic Association of Nigeria. We were the pioneers of that, and then we did a lot of training there in the sort of 2010, 2011, 2000, 2010, 2011. So I think that there is no doubt that the situation is so much more different in the last, 10, 15 years.
Yeah.
Which kind of means that it's going to be interesting what happens in the next 10 or 15 years. So I think, yes, it's been transformational, and I think a lot of surgeons, local and also international surgeons, are offering it available in many areas of the country, which I think is really amazing. In the public sector as well as the private sector, as I'm sure you're aware. I think that's great. We are significantly further ahead than, let's say, our neighbors, Ghana, for example, or Senegal or Cameroon. We are significantly ahead as a group of, I think, of people. I think, which is not that surprising in terms of the Nigerian kind of story. And the thing, interestingly, is that we're talking about robotics. There's a conversation about getting a robot coming through in some of the conversations I'm having on a robot. Wow! I mean, I never expected
It's happening.
to have a correct. It's already happened. I never expected that I would be having a conversation just a few days ago in Lagos around getting a robot or getting access to a robot. I was amazed, but that's just giving you the sort of the edge, going from
Absolutely.
in 20 years, all within 20 years.
Absolutely.
That's just so to show you that things are moving rapidly. But I think, Nigeria has shown a huge promise. I think the restrictions we have in funding and gaps and so on, I think have limited us without a doubt. We need to see what happens in the future.
Absolutely. I mean, the robot is here. It's happening. I mean, you like Kingsley equipment. It's happening in Fuji. It's on the doorstep. I think happy. It's happening. Things are moving along. The question of whether or not we can readily democratize access to it, getting asked down, is a totally different matter. This is a very useful first step. So, speaking still about minimally invasive surgery, laparoscopic surgery, call it keyhole surgery, or whatever it is you want to call it, I'd like to talk about some of the common misconceptions you encounter around keyhole surgery. Thinking really about the understanding of the public. And when, of course, as a surgeon, you have the job of deciding together with your patients when it's appropriate to do that or look to. So talk to me.
And the conversations are a lot easier now. As I mentioned, as we know, that there's been a huge advancement in the positive direction of actually acceptability around the advantages of keyhole surgery, which we used to talk a lot about 20 years ago when we were. So patients do know, and in fact, patients now ask, "I hope it's going to be done keyhole," which is always, I think, a reflection of I think the advancement and, of course, access to best practice, AI, Google ChatGPT, and all of that helps. So I think things are definitely much better. I think there's a lot more acceptance. The challenges still remain sometimes on cost. So, if it costs X on open and costs X on laparoscopic, do people make choices around that based on that? And that can be a little bit uncomfortable at times. We sometimes have to have that conversation, as you know. The other thing I think around that is, people go home quicker, and I think some people don't want to go home quicker, which is a really interesting.
Isn't it?
I've done your surgery at Key or whatever. Go home today. I don't know. I want to keep the patient in for 5 days if you have to, doctor. So I think that's less now. But that still happens. But you see, I think what this all tells us is that, the culture of healthcare in Nigeria has really moved on significantly in my time practicing. and it's interesting, and I don't know if I'm allowed to just bring an anecdote to the conversation.
Carry on, yeah.
I had a patient who came to my clinic a few months ago, and she came in and we were talking. She came to sort of around weight loss, and we were having a conversation. Yes, what do you want? And she said to me, "Yes, doctor. Now, look, I really think the laparoscopic single anastomosis bypass is actually better for me than the laparoscopic sleeve gastrectomy. What do you think?" And I nearly fell off my chair. I said, "Are you a doctor?" She says, "No." I said, "Are you a nurse?" I said, "No." I said, "Where does this come from?" And she laughed. So
ChatGPT, perhaps.
Indeed. And that's just to give you an illustration of people accessing information now. And I'll give you another anecdote, which is really amazing. I learned this for the first time ever, and you may well have not known of that. A lady came to my clinic yesterday and said to me, "Oh, I had surgery in the UK, some plastic surgical procedure, no problem. I had a bit of a wound problem." And she came to my clinic and we were chatting, and I'm thinking, I'm not kind of a plastic surgeon. She comes in, we chat, a little issue with the wound, and she says to me, "I've been dressing it myself for the last 3 days. No, 5 days since I came back from London." I said, "Okay." Says, "What do you use dressing?" "Oh, I'm using silver nitrate, silver impregnated Aquacel." "Right? Where'd you get it?" "Amazon." "Okay. Who told you to get it?" "ChatGPT." "Right. Okay. How?" "I took a picture. Took a picture of my wound, sent it to ChatGPT. ChatGPT told me exactly what was going on with the wound. Correct. Gave me a protocol. It looks like I'm infected. Get a swab. Do this." And she said the picture 3 days later. I said, "Oh, it's improving. There's some capillaries." And I didn't even know you can get that in ChatGPT.
Oh, of course.
It can be a wound management system.
Of course.
I was shocked. Anyway, there you are. So technology is transforming everything we do.
Absolutely.
And I think that's probably what it alludes to. And I think that's why people come, they come armed. And I think the thing is that clinicians need to be flexible. If a patient tries to unbalance you on a question of whether you've done it before, or on a question of, "I think I want this rather than that," we have to be adaptable.
Yes.
That is a challenge. That's culture now.
Absolutely.
Yeah.
Yeah.
And I think that's really the problem. Sometimes the patient says something and you kind of get unsettled and you start to feel the vibe and the doctor's pulling away. No, we have to be adaptable.
Absolutely.
So there.
And that's precisely how all healthcare systems evolve. As you will know, I mean, there was a time in the NHS in which you can draw a line in the sand. You started to get better informed patients in late 90s onwards. And of course, the system has to be robust enough to be able to cope with and deal with that. But of course, chemosurgery, as we've been talking about, is hugely beneficial to the patient in the right circumstances. Very safe, but not without its difficulties, not without its problem. And that's not limited to Nigeria, even abroad. I know, of course, and where Maidstone, Tunbridge Wells, where you work, perhaps some of your colleagues, at what point have you used chemosurgery? So it's not anything that is limited to this country, but really good to know and to hear that increasingly it's becoming more and more accessible to patients up and down the country. So, Abuchi, you recently published a 10-year retrospective study of metabolic surgery at the Aptals in Lagos. You're beaming. You're very proud of that. 381 of your own patients. Okay. So tell me, what were the most important insights from that data set? And how important is local data, by the way, in shaping safe, sustainable bariatric programs in Africa?
I think it's essential. If you recall, I alluded to the gap in the sub-Saharan region, and it's been a real discomfort for me over the years to see sub-Saharan Africa, with the exception of South Africa, put in a basket case when it comes to bariatrics, for example. So to get my data out, I think was really important. It's, it's not not massive numbers, of course, but I think it is still a line in the sand to say, yes, we have been doing the work. So I think that was
81.
So for me, that I think was quite a task, and I'm so grateful for all of my kind of colleagues and those that going to help me do that really. So that it is important. I think we need the narrative change, which is, I think, what you alluded to has to happen, but it isn't soft. It's got to be based on hard facts, data.
Of course.
Anecdotes just don't cut it in the world. You've got to have hard facts, which means that the data's got to be collected, if you can, prospectively. It's got to be verifiable. Now, if the data is collected and it proves that the results are acceptable in international standard, which luckily ours are, then I think it's something to be proud of for the region, really. So yes, I think it is really an important landmark paper that we were luckily able to get published. And as you know, I specifically chose to publish it in African. I did not want to. I didn't want to publish in Europe. I was very specific. I said this has to be published in an African journal. It's African data.
It's important to tell our own story.
Yeah, I didn't want. Yeah, so I definitely wanted it to be published in Africa.
So it's a good time in the conversation to talk about leadership, legacy, and your personal reflection. An entire discourse has been a reflection, hasn't it? So you founded the Bariatric Metabolic Surgeon Society in Nigeria. Can you tell me what gap you felt needed to be filled there, and why now?
I believe it was in 2022. I had a difficult, challenging patient. And cut long story short, it was clear to me, and I actually remember vividly, I was in my car driving to the train station. I was back in England then. And I said to myself, I said, look, you need to start a movement. And it just hit me. I thought, now what did that mean? What that meant is I thought we needed to have better support. I was solo, on my own, pretty much, trying to do this with, and I wanted to bring my younger colleagues and other colleagues together. I had trained a few surgeons by then, through the sort of the mentorship schemes at Eurocare at the time. So I thought, let's all come together. When I founded a society, it's 3 to 4 years old now, and I think it's been helpful. I hope it's had some impact. I think it's just to help support really each other, guide. I think each other. It's a hard world out there in bariatrics and metabolic surgery in Nigeria. I've found that out many times, and you need a friendly space. I think.
Abuchi Okaro, thank you for joining us.
Thank you.
One-to-One.
Thank you. Pleasure. Thank you.